Hello, my dear friends. Our topic for presentation today is pelviureteric junction obstruction. Here on, we will call it as PUJO, pelviureteric junction obstruction. We can see the renal pelvis here and the obstruction in the renal pelvis. Pelviureteric. Coming to the embryology of the development of ureter, we can see that the ureters are developed from the mesonephric duct as a ureteric bud. The ureteric bud develops here. You can see the ureteric bud here developing. It develops and grows here into this part of, you can see here. It grows into the metanephric. This is the metanephric kidney. It develops and the ureteric bud grows. This is the mesonephric duct and the ureter grows like this. This ureteric bud grows like this into the metanephros. So if there is a problem with this development, it can occur in various phases. That is, it can cause problems with the VUJO, vesico-ureteric junction obstruction. It can cause obstruction at the pelviureteric junction, renal pelvis and the ureter, and it can cause also obstruction at the level of calyces and the kidney. So different levels in the development of, if there is a development and defects in the ureteric bud, there can be problem anywhere in the ureter. So pelviureteric junction is one of the most common cause for ureteric obstruction. Now coming to a case scenario, this is what we encounter in our OPD. There can be a 2-month-old child presenting with a history of antenatal hydronephrosis. On examination, there was a left-sided abdominal mass. Renal ultrasound was performed which showed left hydronephrosis of anteroposterior diameter APD, anteroposterior diameter of 40 millimeters. Urine routine was normal. A micturating cystourethrogram MCU, micturating cystourethrogram was performed which was normal. A DTPA renogram was performed which showed delayed activity on the left side. There was retention in postvoidal film and there was an obstructive curve. Split renal function on the right side was 68% and on the left side was 32%. A decision was taken for pyeloplasty depending on these findings. An Anderson-Hynes pyeloplasty, H pyeloplasty was done on left side over degestant. Drain was removed on postoperative day 4. Date of degestant removal was given after 6 weeks and the patient was discharged. Patient was kept on antibiotic prophylaxis. Sutures were removed on next review after 1 week, and after 6 weeks, cystoscopy and degestant removal was done. Patient was followed up with USG and DTPA scan whenever necessary. So this is how the patient with pelviureteric junction obstruction goes in front through our eyes. Many a times we don't understand what is happening, we just go with the flow. So we have to, in each steps there are points where we should understand, which we should understand. We shall discuss one by one. Coming to the epidemiology, the incidence is 1 in 1250 births with a more of a male preponderance. Left side of the children are more commonly affected in 66% it is on the left side, and bilaterality is in 10 to 36%, and it is bilaterality is more when the child is more young. Clinical presentation can be a palpable abdominal mass. It can be found out while working up for urinary tract infection. The children can also present with failure to thrive, malnutrition, decreased weight gain, feeding difficulties due to the dietary crisis where the hydronephrosis causes difficulty in feeding, especially on the left side, nephrolithiasis due to the stasis. All these are clinical presentation of pelviureteric junction obstruction. But these clinical presentations were more common in around 15 to 20 years when the antenatal scan was not very popular. Nowadays, antenatal head scans are more common, and the most common presentation now of pelviureteric junction obstruction is antenatal hydronephrosis. So we should understand how to approach antenatal hydronephrosis or how to assess antenatal hydronephrosis. A typical antenatal scan for antenatal hydronephrosis is taken around 16 to 20 weeks, and we have to understand one more point is that there is only 60% concordance in finding between the antenatal and postnatal scan. Only in 60% of the cases where antenatal scan says there is hydronephrosis, there is a postnatal hydronephrosis. Does all antenatal hydronephrosis means pelvic junction obstruction? No. How will we know which antenatal hydronephrosis has more risk of renal damage? Don't know. How will we understand? So, what are the features of a typical pelvic junction in antenatal hydronephrosis? Let us see. It is generally unilateral or less frequently bilateral pelvic ectasis in 10 to 30%, which is more common in younger. Normal amniotic fluid volume, no evidence of ipsilateral ureteral dilatation, and normal thickness of renal parenchyma. All these are the typical features of pelvic junction obstruction in antenatal hydronephrosis. But life is not typical. Prognostic indicators which showing poor prognosis in case of antenatal hydronephrosis. This doesn't mean that it is pelvic junction obstruction. It only means that in case of antenatal hydronephrosis, poor prognosis is seen when the gestational age of detection of antenatal hydronephrosis is less than 24 weeks. Oligohydramnios, which indicates poor urine production and associated with poor lung development, and bright kidneys, which means poor differentiation of kidneys. Now, how will we grade this antenatal hydronephrosis? How will we know which is a more degree of antenatal hydronephrosis, and how will we know which is lesser degree of antenatal hydronephrosis? In grade 1, there is renal pelvis dilatation. The renal pelvis is only dilated. In grade 2, there is major calyceal dilatation, and grade 3, there is minor calyceal dilatation, and in grade 4, there is thinning of renal parenchyma. But this picture only an ultrasonologist can understand. For us, the visual appearance will be like this. In 1, pelvis dilatation, grade 2, calyceal dilatation, grade 3, minor calyceal dilatation with the blunting of calyces, and grade 4, there is the thinning of renal parenchyma. So that is the Society of Fetal Urologists classification of antenatal hydronephrosis. Coming to grading in terms of numbers, mild antenatal hydronephrosis when the anterior posterior diameter is less than 10 mm, moderate when it is 10 to 15 mm, and grade 3 renal pelvis dilatation with all calyces dilatation, uniform dilatation of all calyces, whereas there is a normal renal parenchyma, and in grade 4 there is thinning of renal parenchyma. That is regarding the SFU grading in terms of numbers in case of anteroposterior diameter. Now, antenatal scan cannot distinguish between true obstructive uropathy and transient hydronephrosis. Many of the hydronephrosis get resolved after the birth. But antenatal hydronephrosis does not mean whether it is a, they don't distinguish between true obstructive uropathy and transient hydronephrosis. Antenatal scan cannot distinguish whether it is a multicystic dysplastic kidney or whether it is a pelvic junction obstruction. Antenatal scans cannot also distinguish whether it is a pelvic junction obstruction or a vesico-ureteric reflux. So, since antenatal scans cannot conclusively say which is the real problem, what we have to do is we have to take a postnatal ultrasound. But postnatal ultrasound has its own problems. We have to understand all these problems, understand the problems of postnatal ultrasound to read the postnatal ultrasound. A typical scenario in an OPD might be the patient will say, yes, we had taken an antenatal scan and it had said antenatal hydronephrosis, but the postnatal scan there was no hydronephrosis and the doctor said it was normal, and now the child is presenting with a pyonephrosis. Scenarios can happen routinely like this in the OPD. For that, in order to avoid this, we have to understand how to read a postnatal scan. How to interpret a postnatal ultrasound. Neonate has an initial 2 days of oliguria followed by polyuria lasting up to 10th postnatal day. So if the USG is taken in the initial 2 days, in the first 2 days, what will happen? There is oliguria. So even if there is some obstruction or some hydronephrosis, it will not be apparent in the oliguric phase. So generally, ultrasound in postnatal ultrasound is generally taken after 2 days. But we should know that the polyuria can last up to 10 months. So 10 to up to 10th postnatal day. So even if there is no hydronephrosis, when the scan is taken between 2 to 10 days, there can be a hydronephrosis. Even if the scan can show a hydronephrosis, even if there is no hydronephrosis. So whatever it is, we should take, even if we should take a postnatal ultrasound in case of an antenatal hydronephrosis to detect the different other problems, to delineate to rule out other problems, or to know whether the antenatal hydronephrosis is still persisting. But even if we take it during the postnatal scan, we should not comment on the postnatal scan conclusively that there is no problem. It should be anywhere repeated after a renal ultrasound should be taken after 4 to 6 weeks. Now coming to renal ultrasound. What all should we look for in renal ultrasound? In renal ultrasound, the parameters which we should check are: 1. Anteroposterior diameter in one on that side of the anteroposterior diameter of the side with pelviureteric junction obstruction, whether there is renal parenchymal thinning or not, whether there is renal parenchymal, whether the ureters are dilated or not, whether there is vesico-ureteric junction obstruction, what is the bladder thickness, what is the thickening thickness of the bladder wall, whether there is residual urine volume in the bladder, whether the posterior urethra is dilated or not, whether the posterior urethral valve, whether the opposite ureter is dilated, and the parenchyma of the opposite kidney should also be looked. So these are the things which you should look in a renal ultrasound. Now, what are the causes of hydronephrosis? Before going further, we have to know what are the causes of hydronephrosis. It can be obstructive. Obstructive can be pelviureteric junction obstruction, which is 44% incidence. Uretrovesical junction obstruction, multicystic dysplastic kidney, it is a lesser, it can be less termed obstructive. Uretrocele and duplicated collecting system in up to 12% of incidence. Posterior urethral valve in case of 9%. Ectopic ureter, urethral atresia, sacrococcygeal teratoma, and hydronephrocolpos can also be obstructive causes. Coming to non-obstructive causes, it can be vesico-ureteric reflux, physiological dilatation of the urinary pelvis, renal cystic diseases, and megacalicosis. So these are the causes of hydronephrosis. We don't know which hydronephrosis is obstructive, and a renal ultrasound will not clearly delineate, say, it can say there is hydronephrosis, but it will not say which hydronephrosis is obstructive. Does the hydronephrosis cause progressive renal damage? The renal ultrasound cannot give that answer also. So, what will we do? We have to go for other investigations in our armamentarium. The other investigations in our armamentarium are micturating cystourethrogram. Why do we have to do a micturating cystourethrogram? Because vesico-ureteric reflux is the most common problem of the lower urinary tract in children and coexist with pelviureteric junction obstruction. In 9 to 14 percentage of pelviureteric junction patients have vesico-ureteric reflux. Voiding so MC or micturating cystourethography or voiding cystourethography is a standard practice which has to be taken before further assessment of hydronephrosis to rule out vesico-ureteric reflux. But this point has been challenged by the newer generation. They say that there is a lesser chance for coexistence between the pelviureteric junction obstruction and vesico-ureteric junction obstruction, and it needs, and only MCU has to be, it's an invasive investigation, and MCU has to be only performed if there are any features suggesting of posterior urethral valve. But the debate is still going on. But anyway, if there is a poor stream, lower urinary tract symptoms, urinary tract infection, or if there is any suspicion of a vesico-ureteric reflux or a posterior urethral valve, we should always go for a micturating cystourethrogram. Coming to our next investigation, it is intravenous urography. Intravenous urography is some kind of an outdated investigation now, only may be used in some case of duple to assess the renal anatomy and assess the ureteric anatomy, but it formed the basis of a lot of investigations which had been followed. In intravenous urography, a dye is injected and the dye goes into the bloodstream and it excretes through the kidney and into the bladder, into the ureter, and then into the bladder, and it is finally excreted out. And during this time, an X-ray is taken during the different phases to visualize how the dye moves. So here we can see in intravenous urography, there is a holdup of dye on the right side with the dilatation of the renal calyces and the dilatation of the renal pelvis, saying that there is a hydronephrosis there is a right hydronephrosis, and the most probable level of obstruction is on at the pelviureteric junction, because we cannot see the ureter, you cannot see the ureter underneath it. We can also see the dye being excreted normally through the other side, and the dye is in the bladder. So this is regarding the intravenous urography. It is not done commonly now, but it is a forerunner of many other investigations. So how to assess an intravenous urography? We can see that initially the dye is concentrated on one kidney, which is generally the kidney which is opposite to that of the pelviureteric junction, because that kidney will be better functioning. Then once the dye is secreted in that kidney down, once the dye is secreted in that kidney down into the ureters, the other in slowly that dye comes in the opposite left kidney also. We can also see that by the dye has reached the bladder here, the dye is getting slowly concentrated on the affected side. We can see that when the dye is in the bladder, there is a holdup of dye at the side of the pelviureteric junction obstruction. In the next film, we can see that the patient has passed urine and there is no more dye in the bladder, but there is still dye present at the side of pelviureteric junction obstruction. That is how the intravenous urography helps to identify pelviureteric junction obstruction. Now, this has been replaced mainly by technetium 99 renal scintigraphy. Even though we say that is a isotope renograms, different isotopes can be used. It can be either a technetium 99 diethylene triamine pentaacetic acid, or technetium 99 DTPA, technetium 99 mercaptoacyl triglycine, or MAG3. Both are preferentially concentrated by the kidney and freely filtered by the glomerulus. DTP is neither secreted nor resolved by the renal tubules, whereas MAG3 is secreted by the tubules. So MAG3 has an added advantage over DTPA, that it gives a better picture in even in kidneys where where the renal function is poor. So how will we assess a renogram, isotope renogram? We get a picture like this in isotope renogram, how will we assess it? In isotope renogram, we have to assess the numbers, we have to assess the pictures, and we have to assess the curves. We will come to it. Now, how will we assess the numbers? If the differential renal function, if the renal function we have already said in our kidney, one it is 32% and another is the 68% in our case scenario. So if the differential renal function is less than 35% in one kidney, it is significant. Then we have to look for the clearance half time. If the clearance half time is less than 10 minutes, it is normal. If it is 10 to 20 minutes, it needs more workup or follow-up, or it is equivocal. Or if it is more than 20 minutes, it is a clear-cut pelviureteric junction obstruction. Or if there is a decremental changes in function by 10% in a repeat renal scan. Suppose now we take a renal scan and it says the function is 40%, and the next year, and after 6 months 40% is 60%, and after 6 months when we take a renal scan, it says it is a 30% and a 70%. So if there is a decremental change in function by 10% in the repeat renal scan, there is a significant obstruction. Now coming to the curves, how will we assess the curves? In the normal pattern, we can see in the normal pattern when the diuretic is injected, initially there is a high rise of the dye in the renal pelvis, and once the diuretic, and then there is a steep downfall. Once the diuretic is injected, there is again a decrease in the concentration of dye in the renal pelvis. In case of a dilated non-obstructed pattern, we can see that initially there is a hold-up of dye in the renal pelvis. The level of dye is high in the renal pelvis in the dilated non-obstructed pattern initially. But once the diuretic is injected, the dye is suddenly excreted and there is a sudden decrease in activity after diuretic injection in renal pelvis. That is how we differentiate between a normal pattern and a dilated non-obstructed pattern. But in case of an obstructed pattern, even if after the diuretic injection, the kidney excretes more and more dye into the renal pelvis, but it is not excreted. So the activity in the renal pelvis goes on high like that. The curve is an upward directed curve in case of a diuretic injection, like upward directed curve. So in case of a diuretic injection, in case of an obstructed pelviureteric junction obstruction. Ureters can also show similar curves like that, but it is not that important. We are more concerned when the region of where the region of interest is the renal pelvis. So these are the DTPA images. We can see in the initial images, one kidney is concentrating dye here. In the second images, we can see the dark spot coming. The second kidney is also concentrating dye slowly. And in the later images, we can see that there is a hold up of dye on one side. This picture is similar to what we have seen in the DTPA in the urogram in the X-ray study which we have already learned. This picture is similar to that. The DTPA pictures are similar to that, but we have to we have to understand that in DTPA, since the picture is taken from behind the right kidney, the right side, this is the left kidney and this is the right kidney. This is the left kidney and this is the right kidney. It is not like what we see in the X-ray. It is in the opposite direction. Since the picture is taken, since this picture or the scan is taken from behind, this part will be the right side, this part will be the left side, and this part will be the right side. Now we can see how will when we have all this information together, how will we read a scan? So these are the perfusion images which we are not much bothered of. These are the renal perfusion images and the renal perfusion curves which they routinely give along with the scan. We are not much bothered about these perfusion images. We can see that if the renal function is much affected, there will be decreased perfusion on one side. We are much more bothered about one. This is one picture we are bothered. This is the isotope renogram excretory phase. He can first in the first picture we can see a cortex. When the cortex is being imaged, we can see there is a diffuse picture like that. And once the medulla is seen, once we start seeing the medulla, we can see that it becomes more and more dark like that. So this dark pictures come when the medulla is being imaged. So we can see on this side, that is on the right, this is the left kidney and this is the right kidney. On the right side, we can see that uh, the dye has come earlier to medulla. On the left side, the dye is only coming slowly into the medulla. That is, the dye coming from cortex to the medulla or the collecting system is slow. So that is the corticomedullary transit is delayed. The cortical medullary transit is delayed on the side with hydronephrosis. We can see as we go on progressing this on the progressive pictures, we can see there is finally there is a hold up of dye on the left side and there is excretion on the right side. So on the side where there is hold up of the dye, the corticomedullary transit is prolonged. So there is a prolonged corticomedullary transit in case of pelviureteric junction obstruction, and there is a hold up of dye in case of a pelviureteric junction. Here it is on the left side. Next images what we have to see are the pre-void, post-void and the delayed image. In the pre-void images, we can see that the bladder, this is the bladder, this is the bladder is already filled, and in the post-void images, you can see the child was not completely voided, even though it is written post-voided, the child is not completely voided, there is still urine in the bladder, but we can see the image is still, there is a hold up of dye on the left side. There is again in the delayed pictures also, there is hold up on the left side. Next, what we are interested in the curves. In the curves, we can see that the violet curve is that of the right kidney. We can see the curve is a normal curve which going up initially, then going down. Whether the left and the dotted green line is that of the left kidney. Here we can see that the curve is an upgoing curve. The upgoing curve is suggestive of an obstruction. So there is an obstructed curve on the left side. Next we are bothered about the numbers. Numbers can be, here we can see the split renal function here. The split renal function here is, on the right side it is 63%, on the left side it is 36%. So it is still significant. There is a, and we can also see that the time to peak, it is more than, it is 30 on the left side, and it is 2.36, less than 10 minutes on the right side, where it is more than 20 minutes on the left side, where is a decreased uptake on left side, and there is an more uptake on the right side. So we know that the left side there is a, and there is an on, and also in the images, and that maybe the images are the most important thing more rather than the numbers and the curve. And in the images we can see the hold up of dye on the left side, which means there is a left pelviureteric junction obstruction. Now, other investigations in our armamentarium are MR urogram. MR urogram is helpful when DTP cannot clearly predict the level of obstruction. We are not sure whether the obstruction is pelviureteric junction or not. We are also seeing some amount of ureters. Then MR urogram is excellent in delineating the anatomy of the ureters. It is one of the best investigation to delineate the anatomy of the ureter. But the problem is it cannot differentiate between whether it is a reflux, whether the dilatation of the ureter is due to the reflux of urine from the bladder or due to an obstruction. Anyway, there is less radiation and the structure is delineated well in case of MR urogram. Other next investigation is retrograde pyelogram. It is generally done peroperatively when we are not completely sure about the anatomy of the ureter or the level of obstruction even after MR urogram. Then there we cannulate the, after doing cystoscopy, we cannulate the ureter, and into the ureter we pass a dye, and with the help of a C-arm we take an X-ray and can delineate the level of obstruction very well. Now, how to decide whether we have to wait and watch policy or to intervene in case of a pelviureteric junction obstruction? For that, we generally follow with the anteroposterior diameter in case of an ultrasound initially. Mild hydronephrosis is less than 12 mm. Moderate hydronephrosis is anteroposterior diameter of 12 to 20 mm, and severe hydronephrosis is anteroposterior diameter of more than 20 mm in case of a hydronephrosis. So, management of hydronephrosis. Once when the child is in the antenatal hydronephrosis comes to us, we have all the investigations in our armamentarium, how we judiciously put together into treat a patient with antenatal hydronephrosis when suspecting a pelviureteric junction obstruction. Suppose the child comes with a palpable bladder or kidneys and a poor urinary stream. First, we have to see this in history. If all these things are present, then it means it is significant. Then we have to take an early ultrasound. We don't have to wait for 2 days. We can take an immediate postnatal ultrasound. And after an immediate postnatal ultrasound, a micturating cystourethrogram has to be performed. In micturating cystourethrogram, if there is a reflux like this, we can see reflux of urine from bladder into the ureters in case of micturating cystourethrogram. That means there is a vesicoureteric reflux or a posterior urethral valve. If the posterior urethral valve is also dilated, then we have to treat the posterior urethral valve or vesicoureteric reflux. After taking micturating cystourethrogram, if there is no PUV or VUR, then we have to suspect suspect a pelviureteric junction obstruction. For that, we have to evaluate the pelviureteric junction obstruction with the renogram. In younger patients, MAC3 or EC renogram gives a better delineation than DTPA. Suppose there is no palpable bladder or a poor stream or palpable kidney, then it is not present. USG after 72 hours is only required. And in that USG, the anteroposterior diameter can be more than 20 millimeters, 12 to 20 millimeters, or anteroposterior diameter of less than 12 mm. If the anteroposterior diameter is more than 20 millimeters, we can go to the high risk pathway of MCU and MCU, PUV, and PUG. If the anteroposterior diameter is 12 to 20 mm, we can wait. We can repeat an ultrasound after 2 weeks. And if the repeat ultrasound also shows an anteroposterior diameter of 12 mm, then we have to go to the pathway of high risk micturating cystourethrogram pathway. If the anteroposterior diameter in repeat USG is showing an anteroposterior diameter of less than 12 mm, or the initially USG is also showing an IPD of less than 12 mm, then we can follow up USG monthly for 3 months. And if two sequential ultrasounds is normal, no further follow up is required. Now, what type of obstruction are we dealing with? Once we have diagnosed that there is pelviureteric junction obstruction, we have to know what type of obstruction are we dealing with. It can be an intrinsic type of obstruction. Intrinsic type of obstruction is the most common, because there is an adynamic segment in the ureter, the pelviureteric junction obstruction. It will be narrower than the rest of the ureter. It will be poorly distensible. But it will be fascinated to see that the probe can be easily passed through this. If there is a deficiency in circular muscle and there is a deficiency in the propulsive action there or a relaxation there, and that is a dynamic segment, which is the most common cause for pelviureteric junction obstruction. Extrinsic obstruction can be due to mechanical factors like crossing vessels, adhesive bands, arteriovenous malformations, and ureteral folds. Abrupt angulation by kinking or compression of the pelviureteric junction obstruction is, uh, is one of the causes for extrinsic obstruction. There can be also intraluminal causes, which is comparatively rare in pediatric patients, like proximal ureteral obstruction, which includes ureteral valves, benign fibroepithelial polyps. Now, on the preoperative day, we have to send for the pre-anesthetic checkup and investigation. However, we are after we have diagnosed and pelvic junction obstruction, we can come in for the surgery of it. We have to take a decision. On the preoperative day, we have to go for a pre-anesthetic checkup and investigations and admit the patient. We have to buy a DJ stent. Generally, now the pelvic junction is repaired over a DJ stent. Earlier, a nephro stent was used. Now it is a DJ stent is used. Double J stent is used. Arrange blood, and we have to write the pre-op orders and antibiotics. Which digestion we have to buy? In generally less than 6 months of age, use a 3 French and 12 centimeter digestant. In 6 months to 1 year of age, we use a 3 French 16 centimeter digestant. That French is the size and the other one is the length. In 1 to 2 years, 4 French 16 centimeters, and in more than 2 years, 16 4 French 4 to 5 French and 16 centimeters. This is the general size we prefer in operating room. If the entire anatomy of the ureter is not clear in the previous imaging studies, a cystoscopic and a retrograde pyelogram can be considered if there is a CM facility. Surgical steps include position of the patient. We keep a roll, and on one side we can also keep a padding like this, a roll and padding to elevate that side of the pelvis. The approach we use, the incision is on the up. Here the obstruction was on the left side, so we put a left upper quadrant incision. An extraperitoneal approach where we cut the skin, subcutaneous tissue, the external oblique, internal oblique, and the transversus abdominis muscle, and we reach cut the transversalis fascia, and we separate the peritoneum away from the transversalis fascia to reach the renal pelvis. So once we reach the Gerota's fascia and we open put a small cut on the Gerota's fascia and we split open the Gerota's fascia to and identify the ureter. Once the ureter is identified, we backtrack the ureter into the renal pelvis. And once the renal pelvis is identified, we prepare the renal pelvis by separating the by by teasing away the vessels from the renal pelvis and identifying the PUJO. So how to prepare the renal pelvis? Suppose this is the pelviureteric junction obstruction here. What we do is we we see the ureter here and there is a pelviureteric junction obstruction. We put sutures like this, or like a this suture is put just below the ureter. All the other sutures are put so that there is adequate uh, size for the new pelviureteric junction obstruction which is being established. So then we have a hole in the renal pelvis like this, a diamond shaped hole in the renal pelvis with the lower lip hanging more than the other lips. So this is the dynamic segment and the pelviureteric junction. We cut open the pelviureteric junction like this after the ureter is being dismembered from the pelvis. We cut open it like this. So then we get a diamond shape and we spatulate. When we cut spatulate a bit, we get a diamond shaped defect in the ureter like this, and we have also a diamond shaped defect in the pelvis like this. After we obtain both these defects, then we suture. When we are suturing, we have to make a few things. There should be a wide pelviureteric junction anastomosis. The anastomosis should be a dependent anastomosis. If there is an anastomosis is here, it will be a non-dependent, and there will be a non-dependent drainage. There should be a reduction of the renal reduction of the renal pelvis, and there should be adequate size for the anastomosis. All these things we have to see when we do a pyeloplasty. Now there is a reduction pyeloplasty. Now all the pelviureteric junction obstruction may not be very handsome like this where we have a classic pelviureteric junction obstruction. Sometimes the pelvis will be predominantly intrarenal. Sometimes the obstruction will be a longer obstruction, and sometimes there can be a crossing vessels like that. So all the pelviureteric junction is not like a textbook picture. So what will we do in those cases? Anderson-Hynes pyeloplasty is the most common pyeloplasty is performed. It is dismembered pyeloplasty. It is classically done in a typical obstruction where we can see we can cut off the pelvis and we can anastomose the pelvis to the ureter like that after spatulating ureter and the reduction of the renal pelvis. It is Anderson-Hynes dismembered pyeloplasty. In case the obstruction is like this in a non-dependent position, to make it dependent, we can do a Foley's plasty. Suppose, to understand this, suppose we are looking the ureter from here, from downwards up. You see this is a dilated pelvis. We are seeing it from the downwards. This is the dilated pelvis, and this is the ureter. In Foley's plasty, we put an incision like this in a Y-shaped incision like this, and we close the incision. After when we put an incision like this, we get a defect like this, and we close it as a V. So that is a Foley's YV or VY plastic. Next is a variant of Foley's VY plasty in case of an intrarenal pelvis, where we put a V incision, we open it up, and we suture the ureter into this diamond shaped opening after spatulating and making the ureter into a diamond shaped opening. Next is a Scardino-Prince flap urethroplasty. In this case, the ureteral obstruction is long. If the ureter obstruction is long, where we cannot bring the ureter into the pelvis easily after dismembering, then we have to do a Scardino-Prince VY plasty. Scardino-Prince flap plasty, where we are using the redundant pelvis, the tissue in the redundant pelvis to open up a flap which can be used as a which can be used as a tissue for the ureter. And when we cut open the ureter, we suture this flap towards the with the ureter, and we tubularize this this flap into a tube, and we anastomose like this. As we have taken tissues from here, there will be a reduction of the tissue in the pelvis, in the renal pelvis. As we have brought this flap down and we have sutured into the opened up ureter, we have adequate size for the ureter. And so both the reduction is also happening and the thinned out ureter is also dilated. And we can also put a degestant. Next is whether to put a degestant or a double gestant or a nephrostand. In double gestant has the advantages. We can see that in nephrostand the tube is brought from the across the defect in outside into the body into the a bag through a hole in the kidney. The advantage is the degestant, there is a lesser amount of tubes for the patient, and the degestant can be kept up to 6 weeks inside across the anastomosis, supporting the anastomosis, and the patient can be discharged postoperatively early. So early postoperative discharge is postoperative by day 3, day 4 we can discharge the patient, and these are the advantages of degestant. But the problem with degestant is that after 6 weeks we have to remove the degestant by cystoscopy. That means another general anesthesia procedure is required for the patient. And also degestant does not help us. An antibiotic prophylaxis is also required for degestant. Now coming to the nephrostand. The advantage of nephrostand, that main advantage is that if there is some amount of suspicion of a vesicoureteric junction obstruction or some amount of suspicion about a leak, we can put dye through this tube from the outside and we can see whether there is an obstruction or not, or whether there is a leakage or not. That is the advantage of the nephrostand. But nephrostand means there is a more amount of tubes. There will be post-operatively up to 10 days the patient may have to be kept in the ward, and we have to see, but sometimes there can be leak from of urine from here and there will be more drainage for the patient. But main advantage is the imaging helps it very much, and also there is no need for any second procedure, because even if there is an increased postoperative stay, there is no need for a second procedure. So there was always a debate whether to put a degestant or to put a nephrostand. But since anesthesia is more and more getting advanced, more and pediatric anesthesia is improving day by day, people are more moving towards the degestion, which is less cumbersome. Now next is whether to put a drain or whether no drain. So the advantage of the drain is that we can, if the urine collects there, we can always identify it and it can be drained. But it means that again a more post-operative day. Without drain the patient, and if the anastomosis is good, and if the without drain the patient can be discharged by around 2 to 3 days. But if there is a drain, it is safer, and there is still again a debate is going on whether they put a drain or not. In the immediate postoperative period, we have to check for the drain output. Consider continuous bladder drainage. If the drain output is increasing, because there can be always some amount of reflux across the digestion, and the drain output can increase if there is no catheter, urinary catheter. So, bladder drainage can be considered if there is increased drain output. After that, it is better to wait and watch, because most of the cases of some amount of obstruction, some amount of increased drain will decrease by over a week. If the drain output is high and a mass is palpable, that is the recurrent pelvic junction obstruction is there. In the postoperative day, when we palpate, there is a mass and there is a drain output is high, or the a mass is palpable. That means there is an anastomotic leakage. Then we have to suspect it can be either due to the loss of vascularity of the ureter due to increased handling, or a kinking of pelviureteric junction obstruction due to a redundant pelvis. Where we have anastomosis, there can be a kinking and causing an obstruction. In those cases, we have to take the patient. We may have to take the patient to the theater and do a nephrostand. We have to put a nephrostand across the pelviureteric junction. Or a nephrostomy has to be done. We may not have the luxury of putting a nephrostomy. Many often we have to go for a nephrostomy. So when to remove the digestion, again still debatable. 3 weeks to 6 weeks, from 2 weeks to 6 weeks, anytime it can be removed. Generally antibiotic prophylaxis is given, but again still debate is going whether to give an antibiotic prophylaxis. Digestion is always a foreign body. It is better and safe to give antibiotic prophylaxis. Now, in the postoperative follow-up, an ultrasound can be performed by around 6 to 8 weeks, and in case by around 6 months, DTPA can be performed to look for the drainage, and a delayed DTPA by around 3 to 4 years to see for a delayed digestion, delayed pelvic junction can be also done. So, in brief, we have discussed about the embryology of pelvic junction obstruction, the SFU grading, different grading of the antenatal hydronephrosis, the importance of renal ultrasound, other investigations in the armamentarium while evaluating a patient with antenatal hydronephrosis like micturating cystourethrogram, DTPA, MR urogram, and work up how to judiciously use these investigations to diagnose antenatal hydronephrosis, diagnose and treat antenatal hydronephrosis, and the differential diagnosis and the different causes of pelvic junction, the decision making in pelvic to decision making, and the surgical steps in case of pelvic junction obstruction. And we have also discussed the different variations of pelvic junction obstruction and the procedures for the same, postoperative management for the patients, and the follow-up of the patient has also been discussed. That is all for pelvic junction obstruction. Thank you. Have a good day.